she did say this is a small beginning and that she will definitely pursue the legislation starting in January.
Well, that's good.
That's exact, and that's pretty much what Terry Bryant and Charlie said. I mean, Charlie said to me, he's like, okay, we'll take this as a small win.
Yep.
So, and I think that's how we, at least right now, need to look at it. We know enough to know that by the way they have phrased things, whether it was the compassionate caregiver status or this, that they have heard us.
Yeah.
Okay. Because a lot of what we said, when we followed up after our meeting with them of, okay, this is what didn't work in Michigan. You have to put in there things like they have to be flexible about hours because of people's work schedules and all the rest of it. They very clearly put it in there.
Yeah.
So we know they're listening at least. So I feel like it's a big win personally.
Yeah, I do too. But I still think there's just way too much left. Like even the hours, it's like, even like as we see it with compassionate care, to me, it would have been nice to say minimum of 2 hours per visit or something.
IDPH put out the Essential Caregiver Guidance for long-term care facilities.
Right, and it's for all facilities.
Yeah, it was put out yesterday.
So I tried to highlight things that stuck out, but like the definition, essential caregivers are not general visitors. These individuals meet an essential need for the resident by assisting with activities of daily living or positively influence the behavior of the resident. The goal of such a designation is to help ensure high-risk residents continue to receive individualized, person-centered care. The plan of care should include services provided by the essential caregiver.
And that can be just as little as emotional support. It does not have to be physical things. I like the part where it talked about too, they only had to stay away from other staff and residents.
Right.
So
it's right here.
So the one thing
essential caregiver will maintain a distance of at least so many feet from other residents and staff and wear appropriate PPE when they're in the facility.
Yeah, but what about when you're in the room? I mean,
it doesn't give any guidance in it at all.
It's like, can you touch them? Can you,
Yes.
No.
Stephen, wouldn't you say because they did not exclude it? Because normally in every other guidance, it said you had to stay 6 feet away. And this guidance doesn't say that. I'm reading that as no, that they're not saying you have to do that.
Right, because obviously right now you have to do that with compassionate care. At least I do when I'm in my mom, I have to wear,
okay.
Yeah, I have to wear a mask, shield.
With compassionate care, there is a provision where if it's deemed necessary, and it can be planned that you can be within the 6 feet and do it without or with minimal PPE if it can be planned out. I think the exclusion of any phrasing like that is in the Essential Caregiver Guidance means that it's going to be left open to the specific care plan for the resident and based on their needs.
Okay.
Right, because I mean, I touch Lynn every time I'm there. I feed him, I help him walk, because it says, if it's can be done safely. I mean, I wear goggles, a mask, a KN95, and a plastic gown is what I wear.
Well, right. So that's obviously, that's, I guess, like for me, what would be nice, I know some of the other states specifically say that you can, hug, you don't need to be, or you can like even share a meal. Like that's what I would like to do with my mom. I'd like to be able to go in and have a meal, lunch with her or something.
No, and I agree with you there. That is still one of my issues because they would not let us have Thanksgiving with Lynn when I wanted to bring it in. I mean, they let me feed him Thanksgiving dinner, but they wouldn't let Jason and I have it with him. Right. So no, I agree with you there.
Yeah.
But this one, I think being the fact that it doesn't exclude things helps give us a little more leeway. I hope.
Yeah. just make sure when you're having that care plan meeting that you're discussing touch
Okay.
and what the facility policy is.
Yep.
Right.
Yeah, I'm just curious how long, these, I could see calling like my mom's facility, I wonder, I guess, again, how long do they have to establish? I could see calling now and they're like, oh, well, who knows? I mean, it could be a month out before they come up with a policy and procedure.
But you're getting in now to see your mom, right, Peggy?
Yeah, compassionate care. Yeah, I get 30 minutes. I mean, which, believe me, it's fine. Well, not now because she came home for Thanksgiving. So they're making her quarantine for 14 days, even though she already got a negative test. She's getting tested again today, and they said it doesn't matter. They said she still, even if all her tests, because they test twice a week, and they said she still has to, I can't come in for 14 days, so.
Well, and after the CDC changed their guidance yesterday, that makes no sense.
Well, that's what I said, but they said that's what they're doing. They're considering my mom a readmission. And they said that's their policy for new admissions and readmission.
A readmission? Now, was did she spend the night with you? I can't remember.
Yeah, oh yeah, I had her for almost a full week. Yeah.
Okay.
Right, and that's the thing. IDPH's guidelines and their like on their Friday meetings and everything else, they very clearly differentiated in one of the last meetings the difference between an overnight visit and leaving for an afternoon. And the risk factor changed the minute they were gone overnight. In their opinion. Nancy
asked me to share hers, so I'm just going to read it from Facebook if that's okay, real fast. Considering what she is, her experience with this since the guidelines came out. She got back with from the director of nursing, just got back to her immediately, and she said even one case in the facility is an outbreak. As far as compassionate caregiving, she told me to talk to the director of social services, who would let me know. But so far, her son doesn't qualify because he has been able to maintain his weight. And since he's been on antidepressants since September, he does not qualify.
And her facility is splitting hairs.
Yeah.
And like I told her, that's why I keep telling her, call IDPH or have them get her connected to the other ombudsman because of whatever the issue is with the local one. They can't, because of the connection. What questions or what thoughts does anybody else have?
I think the second paragraph where they're recognizing the effects of prolonged physical separation and isolation is a big step. And I agree. And if you're going in to help them with daily living, to me, that implies that you're going to touch. So I agree with you. They only say 6 feet when it pertains to other people in the facility.
Today, I'm actually doing my first compassionate care visit today. And I'm actually planning on helping my dad with a shower because he's been to the point where he's been refusing they're not able to get him to do showers and some other things. So I'm going to actually coax him into the shower today. So I'm going to coach him through it, but there's a chance I may have to, touch him at some point too. So, yeah.
Like they say, as long as you have appropriate PPE on, so as long as you're in a mask,
right,
and all the rest of it. When I asked the director of my son's facility, when she read that last night, I'm like, how do you take this? And she's like, you know what? She said, compared to a lot of things IDPH has written, she says, I think this is fairly clear cut. So if they're seeing that that's, at least from their perspective, that it's fairly clear cut, hopefully there isn't as many issues with this as there is with some of the others.
But if there's an outbreak, they can't go in, right? That's what it read in there.
Yeah.
Correct.
What's an outbreak? Is it 1 or 2? I thought it was 2.
It is one.
This is Julie speaking again. I spoke to my director yesterday and she said one person is considered an outbreak.
Wow.
Correct. But I believe now it's one that is in the facility or like counts as, like, we've had a lot of staff come up positive lately, but their staff, like we had one that came that hadn't worked in 4 or 5 days and she didn't count. So I think some of it, at least, because the staff is who gets it first, I think they are looking at the staff a little bit different because of when they were in the building and what their connections were. So hopefully that helps too.
An outbreak has nothing to do with numbers, correct? Like in terms of the state, the county,
No.
Okay.
Right.
Well,
and that's the other good thing about this.
Yeah, that is good. It is good.
It's considered an outbreak if the person contracted it while in the facility.
Thank you. That's what I was trying to get to.
Yeah, if they're coming from the hospital and they're in that transition unit, that wouldn't be considered something that wouldn't be considered them catching it while they're in the facility. Now, once they've transitioned out of that unit, once they've transitioned out of the transition unit, then if they get COVID while they're in the general population, that's going to be considered outbreak.
We got 20 here with it, so they're not gonna let anybody in. They won't let anybody in here at all.
Places like yours, Bruce, even where they're not even letting compassionate caregivers in, that's where the state needs to step. Somebody needs to get IDPH in there because, my son's facility had been an outbreak for weeks and I haven't missed a single visit because of it. I'm nowhere near where that is. So, especially for compassionate, because it clearly says it can happen. This one excludes it.
Don't you have to sign up to be a compassionate caregiver?
Well, you have to request it, yes. But you can request that your brother be yours.
From the administrator?
Sure. Why not?
Is that how you do it? And they're gonna
I
argue?
would tell her that you want your brother to be your compassionate caregiver. You keep telling me you're losing strength in your upper body because nobody's helping you. That's what your brother can do. You've told me that.
Yeah, I'm going back to physical therapy. And they told me I need to get back into physical therapy and occupational therapy. So I got a referral yesterday. I think I'm going to be going back to there and get my strength back up and stuff. So.
And all those things are things your brother can also help you with. And I would just tell them, because it very clearly says if it will benefit the individual resident, period. That's the only qualification.
I just noticed something because I was wanting to. I haven't had a chance to go through it all yet. The Essential Caregivers Guidance. As we were talking about it, excluding people during an outbreak, essential caregivers during an outbreak. That's not what I'm reading. It's
Right
what
here?
I'm reading is. What page are you on?
Yeah.
Yeah, it says, they should encourage it. But when there's an outbreak, then the administrator or director of nursing should determine, which, the phrasing leaves it open that it could be excluded, but it's not mandating it.
I see that.
So, I think that's something to keep in mind if you're told that the guidance says that we can't do essential caregivers because of this outbreak. I would encourage you to point that section out, that it really doesn't say that.
Right. Especially depending on where they have you seeing them. Like in our building, we're in a room up front that is totally isolated. So there's no reason to what's going on in the back part of the building where the COVID unit is to stop the visits up front. So I think that is part of how this will play into that too, depending on the facility and how they're set up and how they're going to allow visits.
If you are excluded due to an outbreak, I would encourage you to discuss with the appropriate persons, possibly modifying your essential caregiver role as needed, to adapt to the outbreak. So, and I'm just kind of spitballing. So, you know, if you were going in 3 times a week to walk with your loved one around the loop and help feed them dinner, well, maybe now with the outbreak, maybe now your role is going to shift to you're coming in and helping feed them in their room, and not walking around. Again, a hypothetical, and I'm just kind of spitballing, but I would really encourage you to try and work with the staff on seeing how a essential care visit can be made to work during an outbreak.
That makes sense. Does anyone else have another comment or anything else about the essential caregiver?
Yeah, no, I think we're just all going to have to see what the facilities, come up with.
Correct.
And I'm going to reach out to my moms today to say, when you're going to have your policy plan, whatever, in place. I'm hoping sooner than later. So
is it subjective? Do they get to decide whether or not you really are an essential caregiver, or it's stated clearly?
It's stated that the resident or guardian. So if the resident can speak for themselves, they can choose who they want. Is that what you're asking?
Well, I'm asking on whether or not it's subjective of whether the resident requires an essential caregiver.
Okay, so this is written that essential is not because of any failure to thrive or anything else. They're clearly stating here, this is being done because of the need, because of the extended isolation. So no, there's no real qualifier for this, like there is compassionate care.
Okay.
Does that answer your question?
Yeah, it does. I live in Illinois now, but my mom lives in New Jersey, and New Jersey's a little bit farther ahead of Illinois. And my sister was deemed an essential caregiver after filling out numerous paperwork for the facility. So in the beginning, they were it's a lot harder to be deemed an essential caregiver now in a few months later, because the facility doesn't want a ton of people in there. So they make it very hard. Like, you have to have a COVID test, and you have to have all of these things, and you have to have an appointment, and that's fine. But in the beginning it was easier, but now they're making it harder to become an essential caregiver.
So let's touch that a second now that you said that. This very clearly says the facilities if they want the test, they're to provide the test.
Yeah.
If you pay for it.
No.
No,
really?
It's right here. It's right.
Okay.
There.
They have to provide that. They have to provide the PPE. They have to provide the testing, everything. My son's facility tests me twice a week, every week.
Thank you so much for all this information. It's really helpful.
We keep telling them we're in this together. That's why we do this. It's also why we want a permanent law, because I don't want to ever go through it again. This mom can't take anymore.
I'm sorry.
No, it's okay. I see my son 4 and 5 times a week now. It's a whole lot better than it was. So, and the difference I can see in him is huge.
Absolutely.
Mm-hmm.
Absolutely.
Yeah. And I'm sure every one of our loved ones.
Well, there's something going on in New Jersey called Sally's Law. That's going into legislation, and hopefully that might mirror what Illinois might be doing.
And what is that?
It is going to be a law. It's similar to what she was just saying. So it's in legislation to make this a law.
Oh,
Okay.
essential caregivers. Okay.
Yes.
So, and that's what we're asking for too, right? And I know the Essential Caregiver Coalition, they are pushing to find a way to get this so we can get it done at a national level,
Yeah.
which truly is
Awesome.
what needs done.
Yeah.
I mean, it's not going to be easy, but that's even more, that in the long run is truly what needs. So it's not this piecemeal of Illinois does this, New Jersey does this, Texas
Right.
does this. There'll eventually need to be a permanent solution, because we've all learned something in the last year that nobody realized could happen. I would have never told you a year ago somebody could keep me from my son for 128 days. I would have told you were crazy.
Well, and there does need to be both. It's not just a state or a federal issue, because your assisted livings are regulated on the state level. So if you want to have full coverage, then it has to be both.
So who do we lobby at the federal level?
That we don't know. I haven't quite figured out yet.
All right.
So, Stephen, does assisted living have any staffing requirements? I'm asked this all the time and I can't answer it because I don't have any experience. What kind of mandates that way does assisted and memory care and stuff hold to?
So assisted living is required to have an appropriate number of staff to meet the scheduled and unscheduled needs of the residents at all times.
That's pretty vague.
Yeah, it is. It is very vague. Supportive living, which is basically it's Medicaid supported assisted living. Their rules in terms of staffing are basically the same as your assisted living, except for when it comes to memory care. And in memory care, it's a 1 to 10 ratio. So they actually do have a required ratio there.
Is that only for ones that take Medicaid, or is that all memory care?
That is memory care in a supportive living, which is, the Medicaid. So it's not your skilled nursing, and it's not assisted.
Okay.
It's just memory care supportive living.
So
Okay,
memory
so while
care
we're
that
on-
we,
Go
so
ahead,
memory
Lucy.
care that I pay for does not have a requirement.
In an assisted living,
Yes, well, from what I understand, if it's not Medicaid, then the memory care is qualified as assisted living.
yes, yeah. And I know, like, there's some supportive livings that have switched, and so they have people who are Medicaid and people who aren't Medicaid. So if it's listed as a supportive living, it's still going to have that 1 to 10 ratio. If it's not, if it is full assisted living, full private pay, everybody's private pay, then it falls under that, appropriate number of staff for the scheduled and unscheduled needs.
Okay.
Which that's a whole nother thing from this, but the whole aspect, which I have talked with the director where my husband was, that they have 4 levels of care, but they don't base any ratio on how many are in each level of care, which makes a huge difference. If you've got somebody that's level 4 care, they're going to need a lot more care and you need a lower ratio. than if you have somebody that is a level 1.
Mm-hmm.
But in the guidelines, there's nothing, no real allowance for that you can hold them to, which is a totally different issue than we're talking about, except I think in all of the places, there should be some kind of designated ratio, because you can argue those words that they have forever.
So Stephen, when IHCA talks about these new staffing requirements that go into law next year in January that have these huge fines behind them, is that just for skilled nursing? Who does that apply to? Do you know?
I believe that only applies to skilled nursing. I haven't read through the law myself recently, so, but they're the ones that have actual staffing. Skilled nursing has staffing ratios, and they're very complicated, complicated ratios. I actually had to make a spreadsheet to try and calculate out, and even that I don't trust. It's there's a lot that goes into it. Like social services director counts for 30%, like can count 30% of their time towards resident care or resident ratio, and director of nursing is 50%. I mean, there's a lot that gets taken into account. But yeah, I believe that's only for skilled nursing.
Okay, because I know they keep talking about it and they're saying, you know, that it could bankrupt these facilities and stuff. And I'm like, but nowhere have I heard anybody talk about what it actually is. And the few times I've tried contacting Illinois Healthcare Association for, hey, can you explain this to us for our end? They don't want to even answer an email to me. Now, of you explaining to everybody about people's rights with the vaccine, since it is such a hot topic.
I'm a regional ombudsman over in West Central Illinois. I cover 6 counties, Hancock, Adams, Pike, Calhoun, Brown, and Schuyler counties. And what we are is we are resident directed advocates. We work at the direction of the resident towards whatever their goals are. Sometimes we're successful, sometimes we're not. And you know, right now it's been a whole different ball game for us. So, you know, with that, a couple of disclaimers on, you know, discussion about the vaccine. I'm not a doctor, I'm not a nurse, I'm an advocate. And so my main focus is going to be on rights and some things that you can do to help and you can maybe watch out for. But I really can't speak to the effectiveness of the drugs or a lot in the testing processes that are involved. So there's my disclaimer. I really started focusing on the vaccines when I saw that AstraZeneca and QMG are working to run a test, a trial of one of their vaccines here in the Quincy area. They're one of 100 facilities, I think, across the country that are working on testing that drug. And in the article from WGEM about that trial, they said that they're going to be seeking out nursing home residents and healthcare workers for the trial. And so I wanted to talk about what residents' rights are. Now, and I think we all know that the CDC and Illinois have designated that the first doses available are going to go to long-term care residents and healthcare workers. I think that's a positive step forward. I know, just kind of poking around on the internet, I know a lot of people feel like that our seniors are being used as guinea pigs. I don't see it that way. The fact that the drugs are getting to human trials means that the actual guinea pigs that were tested on early on are still alive and are doing fine. So I see it as a positive step. Along the same lines, yesterday I was on the Nationwide page. I saw some people posting some speculation and some misinformation about the vaccines. I really encourage you, there's going to be a lot of speculation, a lot of sensationalized headlines. I really encourage you to please research before you share something. The saying from my college days was think before you link. And, you know, we want to make sure that we're sharing correct information and not scaring people away from something that could help them. Right now, there are 3 vaccines that are in the kind of the late testing phase right now, Pfizer, Moderna, and AstraZeneca. These drugs, they've been shown to be mostly safe and mostly effective. And really the big thing that we're not going to know once the drugs are released, if the drugs are released, is their long-term effectiveness. And that's the main thing that we're not going to have. So with all that said, the main right that I wanted to talk about was that long-term care residents have the right to refuse. They have the right to refuse to take the vaccine, even if they're under a guardianship. They still have the right. They can't be coerced by, you know, family members or facilities. There should be a conversation that's had with a resident, you know, trying to find out what their concerns are. You know, at the end of the day, it's their choice if they want to take it or not. And I mean, that's the same thing with any other treatment, any other vaccine. But I feel like after 8 months in a global pandemic, it needs to be restated that residents have the right to refuse it. And finally, when the vaccines are released, I think it's important that as outsiders and even those who are living in long-term care, I think it's important that we have some realistic expectations in terms of the restrictions. The restrictions are not going to go away as soon as the vaccines are distributed. You know, I believe all of the vaccines are 2-part shots, that first shot, and then I think it's about a month later when the second shot is given. So at the very, very least, you're not going to see anything change until after that second shot has taken effect. And that's, again, at the very least. Since none of the drugs have been approved, the CDC hasn't released any guidance yet as to, you know, how long it takes for immunity to build up in a person. And they haven't released any recommendations about what regulations can be released once a person's considered immune. So I was on a call with several ombudsmen and IDPH a couple days ago, and I asked them, you know, what we could expect in terms of the regulations to change. And their answer was that they're waiting on the CDC. You know, kind of like with, you know, the changes, you know, we saw CMS came out with their guidance 1 month, and then the next month IDPH came out with theirs. I can't promise it'll be that quick or that slow, but, you know, I think we can expect there's going to be a little bit of time. And I want to make sure everybody's prepared for that, so they're not beating down the door as soon as the vaccine. I know nobody wanted to hear that, but
it needs to be said. As you're saying that, because sometimes people look at me like, no, there's no way that this is right. We also all have to remember that even though we don't like the restrictions, we don't like the rules, our loved ones have the choice, truly, in the end of the day, whether they choose to follow those or not either. You know, whether it comes to, they don't want you to leave for Christmas or that, but they still, in the end, the resident has their rights to make a decision. You know, the facility has the right to quarantine them. they have the right to quarantine them when they come back, but they still have the right to make their decision.
Well, yeah, but obviously certain people, you can make a decision and then you might not have a place to live. I mean, there are facilities saying if you do this, then yeah, I mean, so yeah.
So Stephen, when the rules say that they have to take them back, they have to let them leave, they have to take them back. How could they pull that? Of saying, well, we're not going to let you, we're going to throw you out or not let you come back.
There are a lot of variables to that I wouldn't be able to answer the broad question. Yeah, I payer status makes a big difference.
So
if
in other words, like
Medicaid or private pay is going to make a big difference. But go ahead. Sorry.
In that, just use that example. Would a Medicaid patient or a private pay be more beneficial that way because they don't want to deal with the feds for not following the rules?
In terms of discharges, generally speaking, there are more protections if you are Medicaid. Now, if you're private pay and you're not paying, or if you're in transition and from private pay to Medicaid and the resident or you as the family member have been dragging your feet on getting the Medicaid application filled out and it's maybe halfway done, there really aren't very many protections for you. That's unfortunate and frustrating, and make sure your paperwork's in.
I think you'd have to look at the resident handbook also and see what they list there as causes for taking you out of the contract or whatever, whether it's for you or for them. And as far as Peggy's mom, how do they call it a readmission if you've been paying her room rent for that whole week?
Yeah, that's a very.
I mean, if you really want to get technical, you're still paying her room rent. They're still making money. So how can they consider it a readmission?
That's a very good point.
But when you come back from the hospital, it's readmission every time too. And I think they would
Jack
just use
was there. They never classified it. I mean, as readmission, I was still paying for the room. That's why I said, it's all such a matter of semantics, even all this, the whole thing with guidelines. You can read anything any way you want it. And it really boggles my mind that 9 months later, we're still bogged down in the same things.
Yeah.
Which all these guidelines have not kept COVID out of the facilities.
Right. Well, yeah, like you say, and it's like, when you just think of, like you say, people, I guess it's like pulling hairs, but when it doesn't even make sense, like my mom now, I'm not going to be able to get in there for 2 weeks. Yet she already got her Monday test was negative. She's getting tested today. They'll know tomorrow. I'm sure it's going to be negative. I mean, it's ridiculous. It's like, but yes, she has to quarantine for 14 days. I'm like, she's going to have 4 negative tests before I can get in. And then they still won't let me in the door. And then that's a very good point. I mean, and she was here for a week and it was great. But yeah, I mean, it's not like, I was still paying her full, like you say, for everything, her room, her meals, it's not like I was getting a week, so that's a good point. So.
Well, and I guess I have a different perspective right now too, because I have my sister still in memory care. My husband passed away. So I'm looking at, thankfully I got a compassionate care visit for an hour when he was in the hospital. And then the facility did let us come in the last 5 days he was there on hospice as much as we wanted to, for which I was very grateful. But I still look at it, like I said from the beginning, I would have rather been going in following the same procedures as staff and have spent 7 months with him, or have spent 1 month with him and had him get COVID and die from it, which he did eventually with pneumonia from COVID, as to lose 7 months and it's still there and he still dies from COVID. I mean, nobody knows what to do. They're grasping at straws is the bottom line still to me.
Well, and like you say, and then they make their own rules. I mean, right now, my mom's facility, when I was going for compassionate, care, before Thanksgiving, they right now are decorating the whole facility. So they got painters in there.
Yeah.
They replaced carpet. They got, I mean, how do you do that? They got people measuring in there for new desks, furniture. I mean, I'm walking in and there's workers running around. Like, I'm like, what? I mean, does that make any sense?
No, and
Well-
you can go in to put PPE on, go in to move a resident in to get the room ready. You can put it on to go in and get the things out of there because they want somebody else in there. But
Yeah.
to actually go in, I mean, none of it makes sense
Right.
in the bottom line to me. But
Exactly.
that's why we're working.
Yep, exactly.
Exactly. I mean, Mary Daniels, you saw when she posted 2 weeks ago that that's how her husband's facility that had been clean this whole time is how they wound up being COVID positive, is because they decided to do some remodel
Right.
and they had outside people in facilities that people are remodeling. You know, we have remodeling going on in our facility, but it's our maintenance people that are there every day that are doing it. They do not bring an outside contractor in.
Well, you know what? Life involves risk. And I guess the
That's
thing is,
exactly right.
they're taking the risk with staff, but they are taking zero risk with the loved ones who are paying for
Yeah.
their facility. So a lot of it.
They're not
goes
allowing
down-
them to take their own risk.
Correct.
Right.
Which I
So it
think-
goes back to rights. I mean, even as Stephen's just talking about right now, advocating for these people's, that's what we're trying to do. Whatever.
Yes.
No, it's basically they've lost their rights, their basic rights
Yes.
through all this.
We should be
is-
included in the acceptable risk or
Yes.
necessary risk category.
Well, and hopefully between getting a law, getting these things here, we gotta hopefully get legislation started in January.
Yep.
And yes, we still have to figure out how to get federal legislation, but obviously none of that can happen until we have after the inauguration and all that. I mean, that's
Yeah.
down the road. But we need state and federal both.
Well, and the other thing is it's brought out the cracks in the long-term care industry, which a lot of people have realized
Yep.
that
Yes.
it's so profit-based. I mean, somebody owns the building, somebody manages it, and then you have the people that are actually living there and doing the work. I mean, that's a lot of layers to make money off of. And until we pay staff an adequate living wage, you're going to get turnover. So you pick and make the steps that you can
Yeah.
I agree.
to make progress, because we're not going to fix the whole thing.
No,
But
but
anything you do helps.
we have made progress.
Yes. Well, we're all here talking. That's progress.
Well, I have a question about the screening. So does that mean it sounds like did you say they need to pay for my test?
Yes.
Yes.
Says they have to provide it.
Yeah, and tying into what you were saying, Lucy, about, we're all here talking, Tamara asked that we shared that she couldn't join, but please encourage everyone to spread the news of the new guidance and the compassionate care guidelines and aren't just end of life. I wish it was more too, but for now, let's make sure everyone that can use current guidelines to be with their loved ones are aware of them. I've emailed local news to see if they can do a story on the new guidelines. Celebrate some progress, but still more to do.
Yeah.
I contacted Courtney from WCIA last night, and while we've been talking, I saw a message pop up that I have a message from her, and I would guess she will do another one. Which is who did the interview with Lynn and I on Thanksgiving, because she wants to stay on this. She wants to follow what happens. People need to know what's going on, whether it's good, bad, or indifferent at this point.
Yep.
And we need, like Charlie said to me yesterday, this might be a small win, but it's a win. We got to take it. We got to celebrate it.
Yeah.
Because had we not fought this hard, ladies, we wouldn't be here.
Yeah.
This
Well-
would not have happened yesterday.
Yeah. I agree.
And individually, be a pain in the butt, about essential caregivers or compassionate care visits. You know, the
squeak-
squeaky
the
wheel
squeaky
gets
wheel.
the grease, and eventually,
Yes.
just
Well,
don't give up.
no, you know, I love you, Lucy. You're making me cry.
Oh, my
Um,
goodness. Thank you.
It's okay.
Not that I'm making you
Um,
cry, but-
no, it's okay. You know, it's one of the things I keep telling people, especially people from the state, if they'll listen to me. And when they do, I'm like, I don't want another person to call me or email me begging, how can I help? Because their loved one's an end of life and they can't get in. I said, this should never go on. And nor should it be that they have to wait till end of life to get in.
No,
None of this should be going on, period. And if that means we got to keep yelling and we got to keep screaming, that's what we do. Because, you know, let's face it, 10 years from now, this could all be us in our parents' shoes.
yeah, or less for me. Who knows?
You know, and exactly, you know, and
And I will tell you,
I don't want,
I
Go
got
ahead.
the palliative or the compassionate care visit in the hospital because the palliative care team from the hospital called me about putting Jack on palliative care. And I said, I think we need hospice care. And I said, my one fear through all of this is that he would die without me ever being able to touch him and be with him again. And they made it happen the next day. So, you know, ask hospice, ask palliative care if it comes up. I mean, you don't
Right.
know unless you ask, and you got to keep asking till you get what you want.
right. So just because a lot of people misunderstand it, do a lot of you guys understand what the difference is between palliative care and hospice? I know you do, Lucy, because there is a definite defined
Yes.
difference, and most people don't realize that.
Palliative care, you can have any chronic condition that you need help managing that affects your quality of life.
Correct.
And that could be someone that's young dealing with some chronic disease. And hospice is obviously end of life, but it's not just the last 30 days or whatever either. So, you know, you just have to ask questions
Right.
and be willing to do that.
And palliative care used properly is a support system like
Yes.
you know, we've used palliative care with Lynn for 12 years probably now. They helped us with the process as we were trying to decide if we were putting a G-tube in, as we were making decisions about certain things that needed done. The palliative care team is who helped me with those things. I would personally think for people with Alzheimer's, dementia, all that, those families more than anybody could benefit from palliative care done properly more than almost anybody.
It's a great resource, and I think it's coming more and more in our society, recognizing the need for it, because a lot of people do live with chronic conditions from early on that need to be managed. One other thing, I really think on something different, I would really like that we start an Illinois Family Counsel so we can keep working at a state level on a lot of
Stephen.
How do we do it?
So I
Well,
said I'd do it.
I
But we
mean,
need his boss to call one of us back.
I'm supposed to have a call with her later today, so I can talk with her about that. I think there's a good framework here already with the caregiver group. I think what it might need is, you know, maybe like a weekly or, you know, every other week, put out an agenda and some guest speakers, so that way when, you know, people see it posted, they know, oh, well, this is, something, we're going to have public health, or we're going to have this group or that group. Let's go and attend that meeting. So
let me ask a question. Like, would they have like statewide councils like that? Like Pennsylvania's?
Pennsylvania does.
Right. Is it mostly just nursing and assisted and supportive, or or is it also involving like SILAs and some of the DD community?
I believe theirs is run by the ombudsman program. So it's going to be your ICFDDs, skilled and assisted. In Illinois, it would include supportive living. It wouldn't really include the SILAs, but I'm talking about what the ombudsman program covers and what we can really speak about. A family council, it's your family council. And so you can define what groups you want to cover. And so if you're gonna include the SILAs, then that's up to you and what you want to do.
Well, because what I'm thinking too is you also need, I'm sure you need some professionals behind you to be able to build this and get enough structure and enough attention to get others to pay attention and join, is why I was asking the question. I definitely think it's something we need to look at. Jennifer, I need a bear or two.
I love it. Thank you. Needed
So
to
do
see
I.
that today.
Oh, wow.
What a great thing.
It's funny.
Jennifer, you rocked our world today. Awesome. Maybe we could talk about family counsel on our following Zoom some. Could we make that
I
a
agree.
point?
I really would like to do that.
And I also, because I want everyone to realize that when your loved ones are in a hospital or doctors, there's that supported care guideline I would print it out because it's actually come in handy for me and some friends to actually have the hard copy and go, okay, here it is. Tell me why I can't come in. The guidelines right there.
Well, everybody have a good week.
You too.
Thank you. You too.